What is shoulder dislocation?
When shoulder pops out of its place, it comes out. It's a traumatic injury. This is called as a shoulder dislocation.
And what is a recurrent shoulder dislocation?
So whenever a shoulder comes out, it comes out frequently. If it comes out once, it will comes out back again. So whenever this process goes on repeating, we call it as a recurrent shoulder dislocation. And this is one of the problem in which the recurrence is very known. So supposedly, if the patient has got shoulder dislocation once, he will have a very high risk of developing the shoulder dislocation again.
So how do we approach the patient with the recurrent shoulder dislocation?
So we always should do investigation, specifically the CT scan and the MRI. Both the investigations are important. The MRI will tell you about the soft tissue injury and the CT scan will tell you about the bone loss, because whenever there is a dislocation, you have loss of the bone of the glenoid. So it's a ball and socket joint, and the edge of the socket gets eroded over time, and that is called as a bone loss.
Any specific clinical examinations you want to discuss?
So we don't examine these patients very harsh, because sometimes it has happened that if we do examination very harsh, the shoulder may dislocate out of the joint. So we just do basic investigation and we do a test which is called as an apprehension test. And supposedly the patient has got apprehension, we'll just stop it here, because it has happened if you examine them hard, it may dislocate at the time of examination, and that should not happen.
So what are the approaches, what are the procedures which are available?
So now, if there is a patient who is having dislocation again and again, ideally the bottom line is it should be addressed anatomically, and we should do a procedure which is called as an arthroscopic repair.
Okay.
So whatever the problem the patient has, so supposedly if the patient has got a Bankart tear, we do what is called as an arthroscopic Bankart repair. If the patient has got an ALPSA lesion, we go with ALPSA repair. SLAP lesion, posterior labral tear, whatever the patient has got the problem, we need to do arthroscopic repair for that.
Okay. So, sir, are there any open procedures available for these?
Yes, open lethargic procedure is one of the procedure which can be done, but we keep it as a reserve procedure, and this procedure should not be performed for a bone loss which is less than 20%. So most of the cases, we will consider arthroscopic procedure as the gold standard. Even if there is a bone loss, we can do arthroscopic bone block procedures or arthroscopic lethargic, and they are better than open procedures nowadays. So by and large, for us at Advanced Hospital, a shoulder instability patient will seldom undergo a open surgery. It will be 99% an arthroscopic surgery, regardless of the pattern of the injury, the structures which are involved, and regardless of the bone loss.
Okay. So are there any specific criteria to decide when to go for a labral repair, when to perform a bone block surgery?
Yes. So if the injury is an acute injury, fresh injury, and not many dislocations, and there is a frank labral tear, we can do a labral repair. In multiple episodes of injury, there is usually an ALPSA lesion that is called as an anterior labral periosteal sleeve avulsion. And in those sort of injuries, we do a procedure which is called as a ALPSA repair. If there is a Hill-Sachs which is engaging, we can do a procedure which is called as a Remplissage procedure. And if the bone loss is more than 15%, nowadays some studies say that if it is more than 13.5%, we do a procedure which is called as an arthroscopic bone block procedure. So, and even if dealing a revision patient, then also arthroscopic surgery can be safely performed.
Okay. So, arthroscopic bone block, as in we have to take a bone graft from something? Or
yes. So, if the bone loss is more than 15%, and in some studies they say more than 13.5%, if the bone loss is more, there is a high chance of recurrence if we do only arthroscopic labral repair. So what we do is we take a bone and we place it into the glenoid to cover the bone loss, and that is called as a bone block procedure. And there are many options, many bone block options that we can do. The most common bone block that we favor nowadays is called as a distal clavicle bone block. We also do scapulospine bone block. We also do lethargic type or coracoid bone block. And in rare cases, very large bone loss, we can do a iliac crest bone block also. So many bone block options are available, but this is a very good surgery for a patient who has a bone loss which is more than 15%.
So are there any advantages of arthroscopic procedures over the open surgery?
So arthroscopic procedure is always better, because whenever we do an arthroscopic bone block procedure, we can concomitantly do the Bankart procedure as well. So we can do the labral repair also, we can do Remplissage also. Okay. Also, whenever we do a bone block arthroscopic procedure, we do it with minimal implants. So there are only a fiber tape encerclage or 2 buttons more anterior and posterior. As compared to if we are doing an open procedure, we need to put 2 screws. It has open surgery. It's a non-anatomical procedure. We have to do subscapular split and then place the coracoid. So ideally, for a regular patient, we don't recommend open letargic procedure nowadays. It is either an arthroscopic Venkart, arthroscopic bone block procedure, and very rarely we could do an arthroscopic letargic procedure. But by and large, arthroscopic procedures are superior because you can anatomically replace like a labrum, the anatomical structures whichever are torn, we can repair them normally. Like if you do an arthroscopic bone block procedure, you will be able to do a full capsulolabral Venkart repair. Whereas if you are doing a letargic procedure, you have to release the capsule and you will not be able to do a open like that good labral repair. So if you are doing a bone block procedure, you can do a full labral repair with an remplissage. And what that does is it makes your bone block extra capsular. So there is no chances of osteoarthritis. So it is seen in studies that if you are doing an arthroscopic bone block procedure, the chances of arthritis post-surgery are less as compared to an open letargic, because open letargic, usually the capsular repair is not possible or not good. And there is a higher chance of abrasion of the humeral head to the bone block itself and to the screw heads also. So these are the things that you need to take care.
So, sir, are there any indications where we cannot perform arthroscopic procedures and only letargic can be done? Is there any?
Actually, in present scenario, it is not, because even massive bone losses can be addressed with the bone block procedure. But yes, there is one circumstance in which you should not do a letargic procedure, and that is a patient who is having epilepsy or seizures. Because in letargic procedure, the conjoint tendon is attached to the coracoid. And whenever there is an epilepsy, there will be like firing of muscles of the conjoint tendon, and that can lead to higher failure rates of letargic. So it is known that when there is a seizure or epilepsy, this bone block of the letargic coracoid fails because the conjoint tendon will pull it on its place. And this can lead to the graft failure, or this can lead to even screw breakage that is described. So if the patient is having seizures or epilepsy, you should not perform a letargic procedure, whether arthroscopic or open. That is basically a contraindication of doing a letargic procedure.